And it's my pleasure to introduce Dr. Rabindra Watson from Cedars-Sinai. And Rabindra is going to be talking to us about actually how you can use EUS, not just to diagnose, but also to treat gastric varices in a therapeutic way. So thanks for joining us.
All right, thanks, and thanks to the course organizers for the opportunity to talk today. So I'm going to be the third of 3 talks on endohepatology. And I think Dr. Chang and Jason set the stage very well in terms of what we're capable of with EUS. I'm going to be talking on EUS assessment and treatment of gastric varices. But I think anytime we talk about gastric varices, it's good to take a high-level overview and just sort of review the anatomy, look at our current strategies, and then I'll touch on EUS at the end, because I think it's a very important area for all of us who treat acute bleeding. So first, the basics. So gastric varices are the second most common cause of GI bleeding in patients with portal hypertension. Compared to esophageal varices, they have a lower prevalence, but up to 65% are going to bleed in over 2 years. And generally, these bleeds tend to be more severe. So all of us who take overnight call for GI bleeding have experienced this at some point. Anytime we talk about gastric varices, it's important to review the anatomy. Every time we went over this in fellowship, I would just glaze over and forgot. But I think it's important for all of us to have some working knowledge of this so we can understand the pathophysiology. Most commonly, so this is our portal vein here, splenic vein, SMV. Most commonly, gastric varices are going to arise coming off the left gastric vein. And they'll form here in the cardia and fundus, and they tend to drain off the esophageal varices or paraesophageal varices up through the azygous vein or hemiazygous vein. So that's our most common scenario. And these are generally known in the Sarin classification as GOV1 or gastroesophageal varices or junctional varices. The important thing to remember with these is that these basically share the same pathophysiology as esophageal varices. So they're essentially esophageal varices that extend down along the lesser curvature, known as GOV1. GOV2 sometimes share this circulation as well, but I put an asterisk on them because oftentimes they'll actually behave more like IgV1, which I'll touch on in the coming slides. So now we have isolated gastric varices. So I'll walk us through the anatomy again. So in this case, here's our portal vein. Usually these varices arise off the posterior or short gastric veins. And then their drainage is through the inferior phrenic veins and oftentimes through shunts. So up to 80% of these types of varices, isolated gastric varices, will drain off of shunts, either gastrocaval shunts or gastrorenal shunts as well here. So that has huge implications in terms of both our treatment as well as when we coordinate with IR in terms of what they're capable of doing, whether it comes to TIPS versus BRTO. This is a simpler diagram. I like this because it's much more clear. So again, when we're talking about IgV1 or IgV2 in the Sarin classification, you have portal hypertension, you have backflow through the left gastric vein or the splenic vein, and here they arise through the posterior gastric veins or the short gastric veins, and then through their shunts here, through caval shunts or the left renal vein. So this is a review of the Sarin classification, as we all know. So these GOV1 varices or gastroesophageal varices that extend down through the cardia on the lesser curvature, they're the most common. You can see the bleeding rate of about 28%. The ones we tend to worry about the most are the GOV2 and IgV1. And you can see the high rates of bleeding here. So these are the ones that I'm going to focus on today in the talk. The AGA just issued a clinical practice update last year. I think for your review, you guys should all review this. I think this is an actually quite important and rational update to how we classify varices. So again, with our traditional Sarin classification, we have our GOV1, GOV2 along the fundus, isolated gastric varices, and then varices elsewhere in the stomach. Their proposal now is to actually base this on the physiology of the varices themselves. So instead of calling these GOV1, they're proposing we call these lesser curve gastric varices. So these are esophageal varices that extend down along the lesser curvature. And again, the reason why this is relevant is because we can treat these the same way we treat esophageal varices, meaning variceal band ligation. When it comes to GOV2 and IgV1, the proposed now category is cardiofundal varices, because as I mentioned in the previous slides, they have a different vascular drainage and their association with shunts. And they behave differently. So we'll call these cardiofundal varices. And then these IGV2 are now called distal gastric varices. So really for our sake, in terms of our practice, we're thinking about lesser curve gastric varices that we can treat like esophageal varices. And then we have cardiofundal varices that we're going to treat through endoscopic means. I'm mentioning these other hemodynamic classifications, again, not to put you to sleep, but these are very relevant. These are more recent classifications that have been developed in the radiology literature that look at the hemodynamics of these varices in terms of the shunts, the afferent and efferent flow. Again, this is important, probably less so for us, but more so in our interdisciplinary discussions with our interventional radiologists in terms of strategy. So there's a Kiyosu classification, as well as a SOD Caldwell classification, again, based on their vascular inflow and outflow and how the interventional radiologist may need to tackle these varices. So today, in terms of management of acutely bleeding gastric varices, as I mentioned before, so gastroesophageal varices type 1 or lesser curve varices, we can ban these. So anytime we see these in an acute bleeding situation, we can go ahead and deploy our bans to treat them. In our GOV2 or IGV1 or cardiofundal varices, we can deploy bans in these situations, but as we all know, that can be fraught with complications and very difficult to handle. So generally, cyanoacrylate glue is the crux of our therapy. And then GOV2, IGV2 tend to be much more rare and difficult to handle, but we will use cyanoacrylate and coils in these situations as well. So more detail. So this is actually a case I had earlier this week. So this was a patient who came to me as an outpatient for evaluation of a submucosal lesion. And then the patient coughed, and then I saw a large clot in the stomach, and this is what we saw. This is essentially a junctional varix just spurting, which was an unpleasant surprise in the morning. But again, in these cases, in these junctional varices, we said, okay, let's get the bander on the scope and deploy a band. And again, we just popped the band on, and it was very satisfying to see we got actually very quick, immediate hemostasis in the situation. So that was interesting. I have not experienced that in an outpatient for a different indication, but again, for junctional varices, it tends to work. Quick note on cardiofundal gastric varices in terms of alternative therapies. So sclerosants, ethanolamine, really, we're not using that nowadays. There's a prohibitive rate of complications in terms of ulceration, perforation, and rebleeding. And a randomized controlled trial in 2002 was published comparing cyanoacrylate to alcohol sclerosants, superior hemostasis, superior obliteration, and time to obliteration. So really, ethanolamine and other sclerosants have fallen by the wayside. Band ligation, as I mentioned, can be an option, but it's generally a poor option for cardiofundal varices. They arise in the submucosa. You have thicker gastric mucosa. It's very difficult to operate this either in anterograde view or in retroflexion. And there are variable rates of initial hemostasis, but generally speaking, if you're in an acute situation and you get a band on one of these things, they need to be followed up for a more definitive treatment, whether that's going to be EUS-guided therapy or interventional radiology to intervene upon them. So let's talk about cyanoacrylate glue. So this has been around for pretty much 30 years with variable rates of hemostasis and rebleeding rates. A recent meta-analysis of 7 randomized controlled trials comparing cyanoacrylate to other therapies, including band ligation and sclerosants, showed significantly lower all-cause mortality as well as lower rebleeding rates. So cyanoacrylate glue has really become the cornerstone of therapy for acutely bleeding gastric varices. So how do we do this? So generally what we'll use is N-butyl 2 cyanoacrylate. So this is a quicker polymerization type versus octyl cyanoacrylate. We'll drop small aliquots of 0.5 to 1 cc's. Generally, I'd recommend against dilution with lipidiol. So lipidiol tends to slow the polymerization. And of course, that would increase our risk of embolization and subsequent complications. And then we'll drop aliquots of sterile water. Probably besides embolization, the other dreaded complication with treating these varices is damaging your scope and resulting in a really expensive complication for the endo unit. So it's recommended you coat your scope and your channel and needle with silicone oil, or in our shop, we tend to use just olive oil in single-use packets. And we just flush that down the scope and along the needle, just to make sure that we don't have any glue that adheres to it. So how do we do it? So we'll use a metal tip type needle, generally a Carlock needle. We'll prime the needle with sterile water. We tend not to use saline, because saline, when that mixes with the cyanoacrylate, will actually lead to early polymerization, clog your needle pretty quickly. So we'll get the needle out, we'll puncture the site, we'll do a quick injection of the sterile water and then glue, and then we'll flush the needle through with sterile water again with another CFC. And then we'll withdraw the needle. And sometimes if you're trying to be clever, and I like to do this, is you can actually give a little spray of glue at the end as you're coming out, and that kind of gives you that cap on the mucosal surface. And that tends to help with either the needle getting impacted or then some back bleeding as you pull out. And then once you're done, obviously avoid suctioning glue into the channel. And then basically we leave the catheter out of the scope and then pull everything out. And that way we avoid pulling the needle back into the channel and getting glue caught in there. And I put this picture of the nail polish remover because essentially the way to clean this off is acetone. So you should have some form of acetone, and usually it's just, Walgreens nail polish remover that you can have in your shop, and then just use that to wipe down your scope tip and the lens to make sure you don't get any glue on there. In terms of adverse events, there's a variety of events associated with glue injection, including needle entrapment there on the varix, precipitating more bleeding, sepsis and septic emboli, but really the two biggest things are systemic embolization and adhesive-related scope damage. So in terms of embolization, PE is really the one we think about. In earlier studies, particularly with lipidial injection, you can see asymptomatic glue embolization in about half of patients undergoing these procedures. And it's one of those cases where if we scan everybody that's going through a glue injection procedure, likely there's going to be some degree of embolization. But the rates of clinically significant embolization are quite low. It's important to be aware of PFO or AV fistulas in terms of paradoxical embolic events, in terms of CVAs, et cetera. Commonly, you'll see a portal vein or splenic vein embolization as well, particularly in the setting of shunts. The main risk factors for embolization is if we're shooting it in too quickly, if you shoot a large volume in, so generally we're doing 1 to 2 cc aliquots at a time and monitoring for adequate hemostasis. If you have high flow rate within the varix, using lipidial, as I mentioned, or large shunts. The largest study to date looking at specifically at embolization was a study that included 753 patients getting butyl cyanoacrylate injection. They saw adverse events in 7% of patients, but only 5 embolic events, 1 pulmonary, 1 to the brain, and 3 to the spleen. So overall, the rate of embolic events and clinically significant embolic events is low with cyanoacrylate injection. So what about EUS guidance here? So as Ken and Jason had mentioned, with EUS-guided therapies and endohepatology, EUS has really opened up our view in terms of all the complex anatomy. So I found in acute bleeding events, it's really nice with EUS to be able to visualize the vessel clearly, target the feeder vessel. There's a higher detection rate with EUS than just looking with endoscopy. And you can target that culprit varix. If you can see extravasation when you use Doppler, we can actually find that varix and then treat it. In addition, you can actually see the cyanoacrylate get into the vessel. So with endoscopic therapy, we're just sort of jamming the needle and hoping for the best. But oftentimes with endoscopic therapy, when we jam the needle in, we're actually going next to the varix, and we're actually tamponading the varix rather than actually putting the adhesive within the vessel lumen. We can use Doppler to confirm that there's a cessation of flow within the varix. We can also look for portal vein or splenic vein thrombosis and look for shunts as well. And this again has implications for interventional radiology to communicate with them regarding TIPS and VRTO as subsequent therapies. And then of course we can deploy coils as well, which I'll touch on more now. So when we talk about EUS-guided coil therapy, essentially like many things we've talked about in endohepatology and interventional EUS in general, we've kind of just stolen this from IR. So we use the same coils that they use in their suite. The advantage of using these coils is that the coil itself contributes to the hemostasis and obliteration of the varix, so we don't actually necessarily need the glue per se. We can use those coils alone. It can limit the amount of cyanoacrylate we have to put into the varix, and then thereby hoping to reduce the rate of complications associated with that. So coil injection and cyanoacrylate injection in combination has been around for now over a decade, essentially. It was first reported in 2009 in a case of a patient who had massive bleeding that was refractory to cyanoacrylate, and they injected a coil successfully. And then in 2011, Ken Bindmiller and his group published a 30-patient study looking at large gastric varices with 100% therapeutic success and 96% complete obliteration after one session. This was followed by the seminal paper by the same group, including 152 patients with either active bleeding or recent bleeding, so secondary prophylaxis, and they had a 99% therapeutic success rate, and again, a very low rate of symptomatic embolization, as we saw in the previous study. And then in 2020, we had a large systematic review meta-analysis, including 11 studies, including over 500 patients looking at glue and coil versus just monotherapy, so coil alone or cyanoacrylate alone. And the combo therapy tended to have a higher technical and clinical success rate than coils alone. A similar adverse event rate to coil therapy, meaning that the addition of the coil plus glue led to less embolization and a lower adverse event rate. So based on this meta-analysis, it seems that this combination is probably the best way for us to go. And then most recently last year, again, another meta-analysis, including 10 studies and 300 patients looking at combination therapy. So any form of adhesive plus a coil, so including gel foam and things like this. And it showed that it was also safe and effective as well. So just to update some of the data on this. So there was an abstract presented this year at DDW, including 7 US centers looking at their experience with glue coil injection. Most of the prior experiences come out of expert centers. And so the question was, can this be generalized to other centers on their learning curve? So 7 centers across the country using glue and coil injection, including 79 patients, and 3/4 of them presented with acute GI bleeding. And most commonly, these were isolated gastric varices type 1s, so fundic cardiofundal varices. They injected a mean of 4 coils into these varices, and then they injected glue or this absorbable gelatin sponge or gel foam essentially into the varix in 80% of these patients. So I'll just run through their table, and I apologize, there are a few typos in their table. But in terms of adverse events associated with this, there was only 1 systemic embolization in this cohort of 79 patients. What's interesting, though, is they had a fairly high rebleeding rate, so a rebleed rate of 15%, which if you look at the previous literature that I presented, it's a little bit high. And again, this may speak to the learning curve that's involved in terms of how you approach this. The other thing I'd point out is that, again, using this gel foam or a gelatin sponge, that tends to get absorbed within a couple of weeks and it doesn't last. So what I'm curious about is whether actually that contributed to some of the rebleed rates. In terms of the reintervention, so those that rebled, they were able to actually treat these again with a second session of EUS-guided coil injection successfully in the vast majority of these patients. Okay, so now we'll get to the fun part. So let's talk about the technique. So what we'll do during EUS is you can see here how well we can visualize these varices in the fundus. We'll instill some water into the lumen to sort of separate the intraluminal and extraluminal collaterals, and that helps us visualize a little bit better. It's a standard needle puncture. Most of these coils you'll deploy through a 19 gauge needle. There are smaller coils you can deploy through a 22. You can see in real time how easy it is. It's a very short needle stick. We can put the coil directly in there, and then we can add additional coils as we need through this, the same puncture. So in this situation, this is a rather large varix. So we're able to deploy 3 coils in here. And then immediately through the same needle, we'll inject our glue. And you can see the hyperechoic glue collecting within the varix here. And then eventually you get this hyperechoic blush. And similar to using a standard needle, you'll notice when we place the glue, we'll take the whole scope out with the needle out to avoid contaminating the channel of the scope as well, and then we'll clean things off. So we re-examined that varix and we noticed there was still some residual flow within there. And so we go back with a second needle, we can actually deploy additional coils in the same complex. And again, this can be repeated as needed. Of course, once you deploy glue into a needle, that needle is going to clog and you can't use that again, but you can actually deploy as many coils as you like through the same needle as you see fit. So here we deployed another coil in an adjacent loop of the same Varices and then some additional glue. And there you can see now a nice blush, and you see this sluggish flow, and you see it become more hyperechoic within the Varices. And that's what it looks like immediately after. And this is at 1 month follow-up. You can see a nice collapse of the Varices, and just you see your coil there with the shadow from the glue, but essentially no further varices are visible. So how do we do this technically in terms of getting the coils in? So we're using here just a standard coil here and a 19 gauge needle, FNA needle. And the coil itself has its own trocar. So what we'll do is we'll pass use the stylet of the FNA needle to pass the coil into the shaft of the needle and keep it straight. And then we'll take out the trocar and then essentially use the stylet of the FNA needle to deploy the coil. So as we advance the stylet, you can see the needle tip here, the coil will come out. And of course, it wants to retain its shape in the coil position. And that's how it gets deployed. So a fairly straightforward technique in terms of injection. In terms of how we approach this, I tend to favor using a transesophageal transcrural approach. What that means is that we have the scope in an anterograde position or orthotopic position in the distal esophagus, and then we can visualize these varices across the crus of the diaphragm. So on these EUS images here, the C delineates the crus of the diaphragm. We can actually shoot across the crus with our needle and then inject in that fashion. What's nice is that you're going, by going across the crus, it stabilizes the scope, and then you kind of avoid going directly across that gastric mucosa that's under pressure from the Varices itself, and then you can avoid some of that back bleeding that can be a bit of a bugaboo. So if you're trying to do this elegantly, ideally when we do this, you can have essentially a bloodless procedure. So you can inject the Varices, inject it with a coil and glue, and see no blood in the lumen when we approach it this way. A quick word on tissue adhesives and how we choose them. So you basically have a choice between our two glues. We have N-butyl and 2-octyl. One polymerizes quickly and one has delayed polymerization, and you have to weigh the risk and benefits of both. So in the literature, most of the studies are looking at butyl, so the shorter carbon group, so 4-carbon group on the cyanoacrylate. Again, as I mentioned earlier, we tend to flush this with water and avoid saline so that it doesn't polymerize too quickly. In the past, folks have used lipidiol. It's radiopaque, so when you're doing this under fluoroscopy, you can see where injection is going. It increases the viscosity, but it also prolongs the hardening, so it increases our risk of embolization, so we tend to avoid this. 2-octyl has a slower polymerization, so again, you have a lower risk of premature hardening within the needle itself, and you don't need lipidiol. But again, if you inject this too rapidly, you run the risk of embolizing your glue. So most of the studies are done on butyl for that reason. In our approach, we tend to use the 2-octyl slower approach for EUS-guided therapies, but we actually inject slowly. So we'll have our techs and nurses on the clock, and when they start injecting, we kind of watch and ensure that we're doing this over at least 45 seconds to a minute to avoid embolization. For smaller diameter gastric varices, we'll actually just deploy coils alone. And again, that avoids this risk of injecting glue in places we don't want it to go. And then if we have recurrent bleeding from diffuse small varices, then we'll go ahead and use a smaller gauge needle and inject glue into these other sites. There are some twists on this technique that have been published on recently. One of these is variceolography. So essentially you're doing this under fluoroscopy. In this way, you can inject some contrast and actually identify any shunts that are present. And then in those cases, perhaps consider just coils alone so we can avoid glue embolization. It also allows you to see under real time whether you've actually obliterated the Varices and stopped the bleeding through either the collaterals or other circulation. There have been investigations, as I mentioned, looking at just coil injection alone, but it tends to have a lower success rate than the combination with glue. And certainly it's more costly as well because we're using more coils per patient. And again, there's been reports looking at absorbable gelatin sponge, but again, I question whether this is actually going to result in durable obliteration, and perhaps really it's the coils driving the obliteration in these types of cases. So a quick word on primary prophylaxis. So as it stands now, as I mentioned, cyanoacrylate is really the standard for acute bleeding and secondary prophylaxis, as well as glue and coil. But what about primary? So this was a randomized trial, including 89 patients looking at glue versus just medication versus observation. And cyanoacrylate injection had less subsequent hemorrhage and equivalent survival to non-selective beta blockers. And so the argument was made, perhaps cyanoacrylate should be used for primary prophylaxis. But at this point, the AASLD does not support primary endoscopic prophylaxis. We published a paper now last year in GIE looking at glue and coil for primary prophylaxis, given all the benefits that I mentioned in earlier slides. And so we included a cohort of 82 patients, and we followed them up for a mean of 3 years. Mean variceal size of 22 millimeters, 100% technical success rate with a 97% rate of EUS confirmed obliteration in these cases. What's particularly compelling in this cohort is that we were able to ablate these varices successfully in 3 out of 4 cases in 1 session, which is very appealing, and over 2 sessions in 95% of these patients. So highly effective and efficient. We did have a few rebleeds, 7.5% recurrent bleeding rate, and 2.5% due to recurrent gastric varices that we treated again with glue coil. When we looked at the number needed to treat to prevent 1 bleed based on the current literature, our number needed to treat was 3. And when we did albeit a rudimentary cost analysis, we showed favorable outcomes versus a hospitalization for bleeding. So I think this is where we maybe want to be heading in terms of combination therapy and primary prophylaxis, given the paucity of available options out there. So where are we now? I guess what I'd leave us with is, EUS-guided cyanoacrylate and coil injection therapy is rapidly becoming the standard of care in centers of expertise. If it's not available to you, straight glue injection works in the acute setting. And then, of course, after you've achieved immediate hemostasis, then refer on for more definitive therapy, whether it's a center with expertise in EUS-guided therapies, or discuss with your radiology colleagues, BRT or. And to conclude, so know thy anatomy. So I kind of breezed through that anatomy, but I think it's important, again, to keep that in the back of your mind when we think about treating these patients with gastric varices. Know your tools, know this before you're coming in at night to treat these patients. Make sure your team knows about what you have in terms of glue, scope care, and so forth. EUS guidance clearly enhances the injection of cyanoacrylate, and so that's what I tend to favor whenever we can do it. And the evidence supports the role of EUS-guided coil and glue injection in actively bleeding varices and secondary prophylaxis. And really now what we're looking towards now is more data on primary prophylaxis. And perhaps, as Ken and Jason alluded to, perhaps this is our one-stop shop where we can actually treat our patients with gastric varices a priori with the EUS-guided therapies. So I'll stop there. Thanks for your attention.
Rabindra, thanks. That was a fantastic talk, and really, I think you need to know the hepatology, the anatomy, all the options. But this is really amazing where we're going with this, especially primary prophylaxis.